hello to everyone. Thanks for the invitation. Again, I'm very pleased to join you, even if only virtually today, and hope to be with you face to face in the near future. So as it was just introduced, we have a lot of good news in terms of obesity management due to the availability or also the development in an advanced phase of new drugs that are more effective in order to lose weight and also target obesity comorbidities, as we will see in the next few minutes. So these are my disclosures that I would like to share. And this is a kind of historical slide because it reminds us about how we have been able to treat obesity in the recent past with liraglutide, which is was the first GLP-1 receptor agonist to be approved for the treatment of people with obesity. This is an overview of the SCALE program, which is the phase 3 clinical program in which liraglutide was was investigated and validated in the context of obesity. So you may recall some studies in people with obesity and prediabetes, or with obesity and diabetes, also with obesity and sleep apnea, and this study in which there was a maintenance of people that had already achieved weight loss. So overall, it looks like the extent of weight loss that was able to be achieved with liraglutide at the dose of 3 milligrams once daily was in the order of 6 to 8% below baseline weight, which at the time this data came out, which was almost 10 years ago, was actually quite significant and impressive. Then we moved to a once-weekly GLP-1 receptor agonist semaglutide, again validated in the context of obesity treatment. And you can see here an overview of the STEP phase 3 clinical program. Again, people with obesity or overweight without diabetes, with diabetes, in other contexts. Again, something that reminds us about the efficacy of this GLP-1 receptor agonist, which is more definitely apparent and greater as compared to liraglutide. So you can see how the order of magnitude of weight loss here is now between 10 and 17 or 18% versus baseline. And again, we see less efficacy in people with obesity and type 2 diabetes, which is something that occurs with basically almost any treatment for obesity. It's kind of an interesting phenomenon of which we understand only some of the components. But I guess we can note here how the pharmacology of obesity treatment has achieved an additional success, because the extent of weight loss is greater in the order of 15-17% as compared to baseline, and definitely kind of like twofold, I would say, greater efficacy or two-digit weight loss in terms of percent weight loss as compared to a one-digit percent weight loss with liraglutide. But the field becomes more interesting today because we have learned that using the backbone of GLP-1 receptor agonists like liraglutide or semaglutide or even others under development, we can think of combining the efficacy and the actions of other incretin-based molecules, for example, GIP, so the combination of a dual, or the development of a dual agonist between GLP-1 and GIP, like tirzepatide, has obviously represented a major advance, because we can build on the efficacy and the properties of GLP-1 receptor agonists and add the specifics of other hormones or incretin-based hormones that can potentially make the results in terms of weight loss more prominent and even more comprehensive or even safer. So this was the case for tirzepatide, the first dual agonist to be developed. Tirzepatide is, as you may know, a drug that targets both the GLP-1 and the GIP receptors. It is developed on the basis of native GIP as a structure, but with some changes in the sequence so that it can bind, again, both receptors. It is extended in half-life because it is coupled with a fatty acid moiety, which binds albumin and prolongs the half-life and prevents the degradation of tirzepatide, and therefore can be administered once weekly because it does have the half-life of more than 100 hours. So there are some interesting pharmacological properties of tirzepatide. It's actually really behaving as a very good GIP receptor agonist, but in terms of the GLP-1 receptor activation, even though the affinity is lower as compared to native GLP-1, this particular agonist induces less downregulation of the GLP-1 receptor at the cell surface as compared to the native GLP-1. So this probably results in a persistent and a high level of action in terms of activating also the GLP-1 receptor. But going into the clinical field and looking at the extent of weight loss we can achieve with tirzepatide, we can clearly appreciate here how we are really going even further, ahead in terms of success for treating people with obesity. This was the study SURMOUNT-1, conducted in people with obesity, treated with 3 different doses of tirzepatide, and you can appreciate how the highest dose, 15 milligrams, is really able to provide a weight loss that is greater than 20% less compared to baseline weight. So these people, start off with a mean baseline weight of 105 kilograms, and they lose, in terms of body weight, percent body weight change, they lose like 22% compared to baseline, so more than 20 kilograms, which is something we have never seen before in the treatment of obesity. One question is, how does tirzepatide, a dual GLP-1 GIP agonist, differ as compared to a single GLP-1 agonist like semaglutide, for example? This was explored, for example, in a head-to-head study in people with type 2 diabetes, in which the participants were undergoing measurements not only of body weight and fat mass, but also an accurate calculation of calorie intake and the level of satiety they would achieve with either drug. And you can see that in spite of the fact that the body weight loss is greater with tirzepatide compared to semaglutide, the fat mass lost is greater with tirzepatide as compared to semaglutide. The calorie intake is similar, and the satiety effect is also similar. So this alludes to the possibility that the dual agonist is not only promoting weight loss by reducing calorie intake and promoting satiety, but also by additional mechanisms that are not yet fully understood. So we have nevertheless, something more in terms of action and something more to understand about what's the mechanism of action of tirzepatide. So maybe some effect on energy expenditure, maybe some change in insulin sensitivity that is greater. We don't know exactly why, but it's probably not only about calorie intake and satiety. We have recently conducted also another analysis to look at the tolerability of tirzepatide versus GLP-1 receptor agonist, and we explored FAERS database, Food and Drug Administration Adverse Events database. So it's a database in which you can collect all the different adverse events that are connected with the use of different drugs. So we did this for tirzepatide. We compared with GLP-1 receptor agonists, and we could see how, for example, yes, there was a little higher level of constipation and eructation with tirzepatide compared to GLP-1 receptor agonist. But interestingly, the reporting of nausea, vomiting was less with tirzepatide as compared to GLP-1 receptor agonist. This, in spite of the fact that, obviously, as we saw also in the previous slide, tirzepatide is more efficacious compared to GLP-1 receptor agonists in promoting weight loss. Also, the occurrence of pancreatitis and diabetic retinopathy was reported less with tirzepatide as compared to GLP-1 receptor agonists. So a very interesting, kind of profile in terms of safety, even though, of course, this analysis has the limitation of looking at data not collected during a rigorous phase 3 clinical trial, but reported in real life, especially in the US, with the use of tirzepatide in real world. But because of that, I think also of some interest. So why is tirzepatide less emetic? That does cause less nausea, less vomiting as compared to GLP-1 receptor agonist. Probably it's because the GIP components, or the agonism versus the GIP receptor, affects some neurons in the area postrema and nucleus of tractus solitarius, and these neurons that are activated by the tirzepatide binding the GIP receptor provide an anti-emetic effect. So this attenuates the pro-emetic effect that is caused by GLP-1 receptor activation. However, the field of dual agonists involving GIP receptor is rapidly evolving. Not to confuse the ideas to anyone, but we should be also open to the data that have recently been generated using a GLP-1 agonist conjugated with a GIP receptor antagonist. So something that, sort of seems to be counterintuitive as compared to what we have seen with tirzepatide. So this molecule called maritide is developed by Amgen. The compound is AMG 133, recently named maritide. Is a very complex molecule. You can see here how it is really composed of a GLP-1 analog peptide in pink, which binds and activates the GLP-1 receptor, and then there is this anti-GIP receptor antibody which blocks the GIP receptor. So as a matter of fact, the injection of this compound promotes a prominent weight loss in humans. This is a single injection causing 15% less body weight at the highest dose. And if you compare the efficacy of this compound with that of semaglutide, tirzepatide, or this triple agonist retatrutide, you can see that in fact, considering also the relatively short period of observation, you have a very prominent weight loss. So this occurs in 12 weeks, whereas for the other compounds we have a longer time frame of observation, and makes us hope that this compound in the phase 3 trials could behave even more brilliantly, promoting weight loss to a higher extent. But this is something we have to, of course, look at once the data will become available. So another combination or implementation of GLP-1 agonism with other components is the conjugation with the glucagon agonism. So having a dual agonist that binds GLP-1 receptor and also glucagon receptor. So what is the rationale behind this other combination? Well, it's because in addition to what the GLP-1 receptor agonism can bring about in terms of decreasing, of course, energy intake, decreasing hunger, increasing satiety, and also what it can do in terms of insulin secretion, the glucagon agonism is able to promote lipolysis, to reduce the fat content in the liver, and can probably also in humans increase energy expenditure. So there is a very strong rationale of combining these two agonisms in terms of treatment or management of obesity. This is something that is currently being explored with numerous molecules, so single agents like tirzepatide that binds two receptors. In this case, these other agents binds these other two receptors that involve the GLP-1 receptor and the glucagon receptor. So you can see here, you can read here, survodutide, mazdutide, efinopegdutide, pemvidutide. I will not show you the data of all these compounds. Just for example, one piece of data is a phase 2 randomized controlled trial of survodutide in people with type 2 diabetes and overweight or obesity. You can see here how this compound given once weekly or twice weekly is able to promote a weight loss in people with type 2 diabetes and obesity of approximately 8 to 9% versus baseline. And of course, this is a relatively, again, a short period of observation of 16 weeks. So you can imagine that if you could prolong the observation, you could observe an even greater weight loss. Another combination is to explore or exploit the effects of amylin agonists. So we know that there is a potential also for combination therapy of a GLP-1 receptor agonist, for example, semaglutide with cagrilintide is an amylin agonist that does affect particularly the brainstem at the level of the area postrema and the nucleus of tractus solitarius by modulating mirror-generated signals, so reinforcing what is the anorectic effect of the GLP-1 receptor agonist that involves primarily the hypothalamus. So this is the structure of cagrilintide. I mentioned just a minute ago that it is a human analog of amylin, and it is modified in order to also have a long half-life of approximately 180 hours. So this allows a once-weekly administration of cagrilintide similarly to semaglutide. And we have data in phase 2 trials of the co-administration of cagrilintide and semaglutide, both at the dose of 2.4 milligrams and both once weekly. You can see here in green, which is the effect of cagrilintide on HbA1c and on body weight in people with type 2 diabetes. You can see the well-known effects of semaglutide on either parameter, HbA1c and body weight, less efficacious semaglutide than cagrilintide on body weight, for example, but more in terms of glucose reduction, hyperglycemia correction. But interestingly, and most interestingly, if you put them together, you have an additive of even more than additive effect on HbA1c, particularly on weight loss. So the reduction of weight versus baseline is in the order of 15-16% over a 32-week period of observation, and again with a shape of the curve that makes us think that if you could extend the observation, you could get even more brilliant results in terms particularly of body weight reduction. So one question that comes up when you treat people with these very potent agents that we have reviewed in some detail in the previous minutes is what is the effect on not only reducing fat mass but also reducing lean body mass, so basically the muscle mass. And we know and we have learned since long that there is an important correlation, almost inevitable correlation between the extent of body weight loss and the extent of lean body mass loss. So in other words, when you lose weight, you don't lose only adipose tissue and fat depots. You also end up losing, although to a much lower extent, some level of muscle mass or protein in the muscle. Of course, you can see how the relationship is such that for a high level of body weight loss, you have a more limited level of lean body mass loss. And also you can see how this occurs almost regardless of the type of intervention. So it does occur with diet, with bariatric surgery, and also with the use of incretin-based agonists. So it's not a new phenomenon. Nevertheless, when you end up losing a lot of weight, you can end up losing, between 10 and 14% of lean mass with incretin therapies. And so that's something that is not that different as the weight loss and the lean mass reduction you can see in other conditions, and particularly in catabolic diseases like carcinomas or chronic inflammatory disease or other types of cancers. And it does make us think about the possibility you may affect body composition not always in a favorable way. So even though this is definitely a challenge, particularly a problem in people who have a risk of sarcopenia or are elderly, do not exercise that much. So it is a challenge. It is an issue. But nevertheless, I think we should consider that it is true that there is an absolute change in these components of the body. So, for example, if you lose 23 kilograms, you lose 17 kilograms of fat and about 6 kilograms of muscle. So it is true that in terms of absolute change, you end up losing muscle. 6 kilograms of muscle is not that little change. But when you recalculate the body composition in the individual at the end of this weight losing program, you can, of course, appreciate how in terms of proportion, the lean mass has not decreased. Actually, it has increased. There's a delta of plus 7.4%, whereas the fat mass in terms of proportion compared to the new status after the weight loss has decreased, in fact. So I think we should look at this data also in the context of the new shape and the new status of the individual that has undergone weight loss, and you will find out that in most cases there is no issue of losing muscle. This can be, by the way, also even further prevented if you were to expose the individual to resistance exercise, as has been recently suggested. So the resistant exercise is not only very important to maintain the weight loss and the loss of fat mass that occurs following an intervention, as we know, but it could be also very important to prevent the loss of skeletal muscle mass, and this could be also one, I think, important component to sort of prevent weight regain, because we know that the more muscle we can prevent, the higher the level of energy expenditure we can activate or provide, and therefore this is a very important component that can antagonize the likelihood of regaining weight after losing weight. So the last part of my talk is in regard to the comorbidities of obesity and how these new drugs have really reshaped the risk of obesity being associated with other organ damage conditions or specific comorbidities. So we have learned that if you end up losing more than 10-15% of body weight, you can really target other comorbidities associated with obesity, not only diabetes, but also cardiovascular disease or metabolic disease in the liver or cardiovascular events. And this is something that has really shown to be the case with the new drugs. For example, this is data taken from a recent review article in which we have explored this issue. For example, the reversal to normal glycemia in people with obesity with these different new drugs is really something that is very impressive. For example, with tirzepatide, the people that revert to normal glucose tolerance are almost 100% of the individuals, whereas at baseline there were only 60% with normal glucose. So these drugs can really make a major impact in the normalization of glucose levels in people that have impaired glucose tolerance. And this was shown in the recent analysis of the SURMOUNT-1 extension, in which they measure the incidence of type 2 diabetes in people with obesity and altered glucose or pre-diabetes at baseline. You can see how tirzepatide really, blunts in a dramatic way this risk. So the basically the people that develop diabetes are really less than 2%, whereas without treatment with this pharmacological agent, they would be around 15 or 16%. So very prominent, important data in the prevention of type 2 diabetes development in people at risk for this comorbidity. Similarly, we could conclude for cardiovascular disease. In the SELECT trial with semaglutide already, it was shown that there was a reduction in the primary cardiovascular composite endpoint in people with overweight or obesity and cardiovascular disease. There was even an effect, statistically significant, in reducing the heart failure composite endpoint. And in a separate study, people with obesity and heart failure with preserved ejection fraction, which is the most frequent type of heart failure in people with obesity, you can see how semaglutide improved the Kansas City cardiomyopathy questionnaire related to the clinical domain, and also improved the 6-minute walk distance, which means that people were less suffering from heart failure and could perform more in terms of physical exercise. And if we move to another condition, for example, metabolic dysfunction associated steatohepatitis with liver fibrosis, you can see how tirzepatide is able to improve MASH with no worsening of fibrosis compared to placebo, and also to decrease the stage of fibrosis without worsening of MASH, again, compared to placebo. It's a phase 2 study in people with this biopsy-confirmed metabolic dysfunction associated steatohepatitis with an average of stage F2 or F3, which means moderate or severe fibrosis. Very prominent data, which only have the limitation of being data in a phase 2 trial with relatively low numbers. But I think it's a very brilliant proof of concept that this dual agonist is able to target this metabolic dysfunction of the liver. We alluded to survodutide as a GLP-1 glucagon dual agonist, and this was also shown to improve MASH without worsening fibrosis after 48 weeks compared to placebo. Probably even more convincing data in terms of magnitude of the effect, and again in a population in which MASH was biopsy confirmed and ranged the fibrosis from stage F1 through F3. You can see how these publications achieve the highest ranking in terms of journals like the New England Journal of Medicine, because it's something that of course covers an unmet need in metabolic disease management. And even respiratory function can be affected by these agents. For example, tirzepatide was able to reduce the apnea-hypopnea index in people with obesity and sleep apnea, both when CPAP, so the device was applied to these patients, or in patients in which this was not the case. This was very much related to the great ability of tirzepatide that we have already seen before in promoting weight loss. So close association between the extent of weight loss and the improvement of these sleep apnea indexes. So, and this is my last slide, I think we are really seeing a new scenario of good news, of improvement of not only obesity outcomes per se, but also obesity-associated outcomes that can be more efficiently targeted with these agents, either already available like semaglutide, tirzepatide, or under active development like the dual agonists with glucagon, or even the triple agonists I did not talk about, like retatrutide is a triple agonist with very prominent effects on body weight loss and also liver fat. And you can see here how there is a constellation of comorbidities around obesity involving atherosclerotic cardiovascular disease, CKD, sleep apnea, infertility problems, knee osteoarthritis, type 2 diabetes, heart failure, metabolic associated dysfunction of the liver, and you can see how there is evidence, that some of these agents have been able to target these other comorbidities, but I would expect in the future that we will see more and more of these, kind of circles around the specific comorbidity, and showing then that we have even more than one drug or tool to target that disease. So I think it's a very interesting and bright horizon we have ahead of us, and we definitely will be able to treat more effectively and hopefully also very safely people with obesity with all these problems. I will stop here and thank you for your kind attention.